Great. So with that, I'm going to open the floor to questions and just go to one or the other mic. But just to pick up on Danielle's comment, and actually would like everyone's input on that, there seems to be this gulf between what goes on in the consumer space, and then for those who need to get into healthcare, we're in terra incognita, and where we don't have the tools, as you say, and in fact, often it is it's not at all transparent how they get the assistance they need, unless they have their own local doc who they've been going to for 10 years, who knows them really, really well. Then maybe you can sort of say, here's my report, help me. Otherwise, it just falls into this big gap. We saw evidence directly from that in the presentations earlier this morning. But what do we need to do if we're planning for the future in terms of what's actionable? What do we as a community need to do to fill in that gap or come up with the kinds of tools and pathways that are well appreciated by both the consumers and by the healthcare ecosystem at the other end, so that people can be shepherded across that gap as a legitimate entry into one of the ways, as I said in my introductory comments, one of the legitimate ways that people enter healthcare, and that we develop all of the tools and the processes that allow that to happen in a somewhat seamless manner. So I'll let anyone go with that.
I'll throw one out there. The direct-to-consumer companies often provide information about genetic counseling or next steps, but those could be more directive, particularly for those patients for which we know findings could impact their medical management should they be confirmed, or who are collecting, for example, information about family history for which their test is not going to provide great information on. So we could ask our colleagues in those direct-to-consumer spaces to provide more resources to their consumers in terms of next steps.
So that puts the weight on the consumer end, the DTC company end, as opposed to the provider or health system end. Putting more weight on the providers, as many people have commented, is just seems like a non-starter, right? In fact, at Geisinger, one of our rules right from the get-go was don't add more work for the primary care physicians, because that's a non-starter. They've got a workflow. They would tell us, don't mess with our workflow. They were happy to provide any assistance to a patient who needed that assistance, but don't mess with our workflow. And it's worked very well at Geisinger. That plan may or may not be transferable to any other health system, but it works after a lot of hard work on a lot of people's time, including the providers, found a way to make that actually work.
I think that that's just one possibility. Another there are, for example, a clinic that I believe is at UCSF, which is dedicated to direct-to-consumer genomics and trying to enfold those individuals back into medical care and help transitioning them, or verification programs such as the one that my company is working on to, again, help give those individuals providers about the tests that they've had and what are the next steps that they need to take. So there's multiple options out there.
Anyone else?
Yeah, I think when you say don't add, to providers, it's sort of which providers, right? So the general providers agreed, like they're on the front lines, they're seeing lots of patients. To sit down and do this customized counseling about particular conditions is challenging both time-wise and knowledge-wise. But I think the other entrees that people use to get into the system, like direct-to-consumer or through genetics, the whole idea of pretest counseling, right, is you sit and you customize the experience. So kind of, there's one push, like, more is better, just take all the tests, why not? And then my feeling is in order to actually make this a good experience, you have to really look at the particular situation, because a lot of the problems that I see are when people sort of just did this blanket, oh yeah, this is all good, but it wasn't the right target. So examples, we'll see, again, I'm seeing more companies go out, or reps in detail practices, primary care providers, frontline providers, who then start sending tests with this notion like it's not such a big deal, I'll just refer the problems or the positives. And so like as an example, in the Bronx of our population, certain community health centers is Puerto Rican and Dominican ancestry, and so a rep will go to that company and say, do this panel, it's an Ashkenazi Jewish carrier screening panel. So then for 6 months, we'll get all these Puerto Rican and Dominican women getting referred in with like variants, and they didn't get standard of care testing because they got an Ashkenazi Jewish carrier screening panel, which is completely inappropriate, but it just started rolling out, and all of a sudden you've created this big, mess. So I think the point is, like I said, there's two tensions. One is like panels and more and bigger and better and quicker and faster, and then all the patient experiences that are problematic are like, this wasn't customized to me, this wasn't really my situation, this wasn't exactly. So like how those two are going to meet, I think has got to be, well, number one, pre-test. Like you got to have some conversation about this. So I'm not saying I don't think direct-to-consumer's here. It's here. But maybe even a checklist. Like, if you're going to do this and you're not Ashkenazi Jewish, know right up front before you do it that you're not going to get the full spectrum of clinically available breast cancer genetic testing in 2019 and not just bury it in the post-test thing that you have to flip through. So maybe checklist something like that. Do I qualify? Am I getting the best option?
Go to some questions. We'll start there.
Not necessarily a question, but something that I've learned, and this is a hard left based on the conversation that we've just had for the last 5 minutes, but I kind of feel like DTC testing is dead. Long live DTC testing. The two markets, I think, as we've said earlier today, I think are going to begin to converge. And really what we're talking about here is the difference between diagnostic testing and healthy population screening testing. All the nuances between the regulations and privacy and security, I find those to be fairly ubiquitous, whether you're talking about a consumer audience or a diagnostic audience. So I think, as we move towards a single chemistry that can inexpensively gather all of the copy number variation, all of the translocation information, all of the single nucleotide variants, you have the backbone for all applications, and that should be managed in a certain way. But then there'll be some nuances in how you actually do the interpretation and the reporting in a healthy screening population versus when you're actually trying to rule out a specific diagnosis for someone. I found the group to be very interesting and very stimulating when thinking about, okay, how are these two areas becoming more and more alike? And so I guess it's kind of a provocative thought, but I kind of see these things as merging into one.
Anyone want to take that on?
So actually, I wasn't going to, I want to just pull on that thread a little bit because I always know it's been a good workshop when my head's about to explode at about 5 o'clock. But I do think, in a certain sense, collecting the data, we should all collect data in a rigorous way, whether it's for research use, for setting hypotheses for new drugs, or for diagnosing a patient. And I think next generation sequencing and a lot of the new technologies will get us sort of good quality data. But it's the interpretation and the provision of the result back to the individual in a fit for purpose way for what they want that is the thing that defines whether I want to know who I'm related to or my ancestry, or whether I want to know if I've got a BRCA mutation. So I think that is an interesting point, but, and as several people have said today, unless we're going to have universal health care, and it keeps coming up every time we have these conversations about genomic medicine, it's really hard because we have a healthcare business, or healthcare is a business here, not a service, and DTCs are businesses, and so I think, to me, that's where it sort of starts to not work. But so that was me just pulling the thread of that question. But what I wanted to say was, so we can't burden physicians anymore. I spend more time teaching my physician about genetics, then that's not the answer here. Unless we do have well-educated physicians, but even then, what are they not going to do if they're going to be talking to patients about genetics? Because there aren't more than 24 hours in a day, so something else has to stop, which I think is not necessarily the purview of this round table, but I do think that if we just have to make this more important than some other thing, I think, that physicians do, in terms of helping their patients understand what their genetic tests mean. And then, so now finally to my question, what do the panel think about maybe making more use of patient advocacy groups or registries? Because we saw today, and Andrew showed the Michael J. Fox Foundation, and there are many of these examples. I mean, is there, maybe this could be a way forward to connect DTC and healthcare and resolve some of the issues? I just wonder what... And that's not a yes/no answer, by the way. I didn't ask an open-ended question, but I meant to.
No, I think that's an amazing idea, because once you get to the place where now it's like this gene, your result, this gene, now you want to find subject matter experts in that area. And certainly in the age of social networking, even at 2 a.m, you can probably find someone who's gone down that path and has a tremendous amount of expertise. So I actually think it's a great idea, because, on especially rare diseases, the folks who've been in that experience have that wealth of expertise. There's a little question of sometimes people who aren't so happy with how things went for them can get into that same conversation, so how you'd provide it in an unbiased setting. On the other hand, I think there's a wealth of expertise there that could be tapped in a sort of social networking framework.
My comment on it is that I think that the system is very inefficient right now, and that there are people spending a lot of time on things that they don't need to spend time on, and therefore they don't have the time to spend on things they should be spending time on. So my view of it is that, first of all, we ought to get genetic counselors back to being counselors and not pure education, and that we should that there is an opportunity for technology like chatbots, other sorts of approaches that will allow people to interact in a way, but in a very efficient way, when that's appropriate. The other is, I think, maybe we ought to be thinking more about genetic testing from the point of view of triage. That we need more experienced people who can triage where the testing is going and what the appropriate testing is. And to get that out of the way and get that out of the way quickly, and then get people into the hands, depending on either how they present or what the result is, get them into the hands of the right people based on their presentation or their results, and not waste time with people who don't need that kind of high touch. I mean, for example, someone gets tested for, let's say, hereditary breast and ovarian cancer, and they've got family history, and they test negative on some, big panel. They still need to have counseling. They still have risks. They still need to know what to do. Just because they tested negative doesn't mean, nope, goodbye. So I think some level of triage would be helpful. I'm repeating myself.
Sorry, Bob, can I ask a clarifying question there? Triage, is that at the level of test ordering or at the level of interpretation and return of results? I mean, if we get to singularity in testing and $50 to generate high quality DNA sequencing, it almost seems like investing in triage up front is an inefficiency to the system versus getting the individual in, getting the sequencing, and then trying to understand in parallel, okay, what type of interpretation do we need to give? What type of return of results? What type of counseling on the back end? Therefore, we can eliminate some of the redundancy in the system.
Yeah, I've thought a lot about that, and my worry is that particularly as panels get larger and larger, and then people move to saying, oh, well, I'm just going to do a whole exome or a whole genome, that if you don't have the patient's clinical and family history data to inform you, it becomes difficult to impossible to interpret VUSs. Yeah, and that delivery of VUSs to me is a hard fork in the road. That if someone is adopted, has no family history, has no personal history, or there's no family history, and then comes in for a genetic screen, to give that person 150 VUSs is not a benefit for them. On the other hand, if they have a clinical indication for the test, and there's actually an opportunity perhaps to go back to their family and resolve the VUSs, then it's worthwhile reporting them. So I think some upfront triages would be helpful, but we should try to make it very efficient. I actually don't think that it even really requires a person. I think it can be done with technology.
So just a comment, I think that we identified a gap for consumers/patients, and many factors go into whether that feels like a quick gap over a weekend or a chasm. And there is, certainly it's been brought up that there's mistrust of the medical system. And we heard earlier from Sadie, it's really important to meet patients where they're at, right? And having that ability to connect. There are plenty of, I just want us as a group to be thoughtful about how we're going to fill that gap. I know, Bob, you just said maybe it doesn't even take a person. And you might be right in certain instances, but I think that there's plenty of new vendors, companies coming in, both at the upfront part and the back end part and telehealth. And I think we need to be very thoughtful about how we jump to that as a life preserver as we're facing this onslaught of helping to shepherd people, patients across this chasm. So I just wanted to put that out there.
Thank you for that. Jeff?
So Vince Bonham is sitting in the front row from NIH and NHGRI, and he's very interested in genomics and disparities and the integration of consumer genetics into healthcare. And I want you to consider yourselves advisors to Vince and tell him where you think he should place his bets in terms of funding the next series of proposals that NHGRI will put forward in this area. So what are the real compelling research questions that Vince can take back to NHGRI and place into RFAs for all of us to apply for?
You mean other than polygenic risk score?
For example. No, seriously, there's a lot of really interesting questions up here, but I'd like you to put yourself in the mindset of, like, how do we catapult this meeting forward into, and it's my bias that research is needed to really get to where we want to be. So if you could help us figure out what the research agenda would be, a few ideas would be wonderful.
Let's just say quickly, and I think it's pretty clear that the same level of information and knowledge that we have about genotype-phenotype correlations from people from Northern Europe needs to be expanded to the world.
I'd like to make a comment related to a comment I made earlier at lunchtime about open source data. So what can we do? What kinds of research can we explore so that we can encourage more data sharing among commercial companies? We know that federally there are mandates for federally funded research to place data in databases like dbGaP, and we've also considered the ethics of shared databases within federally funded research. What conversations do we need to have with regard to encouraging sharing among companies? Why don't companies want to share? And what incentives can we come up with for more data sharing? And this is particularly important for underrepresented populations, especially populations with ancestry from Africa, because of the complexity of the genomic diversity among those participants. And so if we have African Ancestry collecting data, Ancestry.com collecting data, all of the other companies collecting data, but they're not talking with one another, then that's a missed opportunity for coming together and understanding all of these diverse variants.
I would add that, as we heard, that the costs of generating a whole genome sequence is going to be really relatively affordable. The burden of genetic mutations in our population, though, is quite high. Disease-causing mutations is probably in the billions in our U.S. population. And those are the ones that we probably can easily identify as being deleterious. But there's a lot of other genetic changes that we don't understand. So I think understanding how to, innovative ways to figure out what a genetic change means, how to annotate that, how to interpret it. I think a lot of effort could be used, and a lot of resources could be used to understand that.
I would say,
I'm going to go way out on a limb on Shonika's comment, and that is, if you want private companies to share their data, you're going to have to incentivize them. And the quickest way that I know to incentivize them is if you don't put your results into ClinVar, you don't get CLIA certification, and you don't get paid by CMS or by private third-party insurers. Because putting your variants into ClinVar is probably the single most important quality control issue that we have to be able to compare how different laboratories are interpreting variants. Now, that's with a disclosure, which is, I was one of the people who started ClinVar, and Invitae is the #1 submitter to ClinVar by far.
Does it work for pharmacogenomics?
It will.
I think, oh, sorry, go ahead.
No, I was just going to add, I think the point that was just made, sort of transparency at the end of the system, putting data into ClinVar. At the front of the system, I think the payment issues are very murky and cloudy and could be cleaned up. So, if a patient comes in regards to what genetic counselors spend a lot of time doing, they spend a lot of time pre-certifying tests, seeing if it's going to be covered, seeing what the out-of-pocket is, seeing if the patient can meet that. If not, so sort of and it's very unclear what the cost is going to be. And I think one piece that the direct-to-consumer companies have done very clearly is like, it's $99 or, it's whatever. And then on this day, it's a sale. Like, people understand that. You swipe your card. Like, there's a more clearer sense of money and how money's going back and forth and what you're buying and what you're getting, which is completely obscured in our clinical care delivery system. And so I'd say that also, I'd like to see us find a way to enhance equity, diminish disparities, engage a more diverse population. People know, what a sale is. Like, if it's cheaper, they'll buy it. These are not foreign concepts. I just think that we're sort of playing back and forth in these two systems, but unfortunately, I think we're potentially increasing disparities by not finding a way to merge these, although I think, again, there are ways around this. It just has to be the will to actually do it and say it's worth it to engage folks who aren't in our database that we want in our database. We're going to make it a cheaper alternative.
I think, when I think about where the investment needs to be in the coming years, we've created a really good shovel. And we can dig a lot of dirt right now, but we don't know what to do with it as efficiently as we're creating it. So, we just been talking over the last 15 minutes about shortage of professionals, genetic counselors, laboratory directors, people who interpret variants. That doesn't scale well at all. It's going to take a very long time for us to educate the sea of professionals that it'll take to do all of the interpretation. So, this may be a little bit of an obvious statement and a bit of a retread, but working with computer algorithms and AI to really help automate the system as best we possibly can, to me, that's a great place to place future investment dollars for new discovery, because we're creating lumber faster than we know how to nail it up and use it. And so why build a better steam shovel when you really need to be thinking about how do you really distill down the nuggets of gold?
You got that, Vince?
Actually, I have one more too. I'm not on the panel, but I'm getting up and I'm going to speak anyway. And I'm just hearing a lot about genetic counselors and how best to utilize them, who needs to see them, how best to have them practice at the top of their scope. And I think, again, we're talking about a lot of issues. We're thinking about how do we practice at the top of our scope without doing some of the things that we don't need to do with our degree. I think there's also, that ties into the efficiency, but I also think there's a big question about who can benefit most from seeing a genetic counselor. And I think research can be done in that area as well. I would think it would be we talk about tiering, there was a question about tiering, but we know that we're not using good tiering methodology right now, positive versus a negative result or whatever it might be. That's not the way we should be tiering who gets to see a genetic counselor, who doesn't. So I would love to see research more thinking about all the different things that could influence a person's need to talk to somebody about this and have that conversation. And that could be anywhere from psychosocial indicators, levels of anxiety, personal control, all of those things could potentially play into that. So I would love to see research around that piece.
If I could just follow up on Kathy's comment just quickly. One of the things that we've given some thought to in terms of the report that we provide back to our patients is to give them some of that baseline education so that they can use their genetics time more effectively to follow up on those individual questions that really need to be personalized. So based on their particular family history or their life circumstance, I have a 25-year-old daughter, they've gotten some of the basics already and they can really drill down into what their individual questions might be. So it kind of takes it, instead of to a result disclosure, to a second kind of or third meeting, and so that they can really dig in on those.
Hi, Elaine Collier from NCATS at NIH, and I just wanted to go back to what Dorothy mentioned when she spoke when this panel started, and that's education of patients, public. I think that this is an area, if the panel can, or the roundtable can actually address it related to this. Again, people know about buying things, as was pointed out from the panel, but value is also important, and it takes understanding to do that. And also, I think it will help us across the board as we move forward with more genomics in the future. It's not going away.
Thank you for that. I think we have time for, you have 16 seconds. No, time for one last question. Alyssa?
Hi, Alyssa Levin, Helix. That's actually very much aligned with what I was going to say, which is I've been in the consumer genetics industry for 15 years, sort of since the beginning, and a genetic counselor for longer than that. And one of the conversations we have over and over again is around educational resources. And there are so many, whether it's public or private efforts that are recreating the wheel around education. How can we appropriately set expectations about what our genetic information can tell us and what it can't tell us? And, there are lots of creative solutions. There's lots of social media. There's lots of other media resources that we could think about in terms of how we appropriately educate the population. We just really haven't had a concerted effort to, I think, do that effectively. There was an effort that was being spearheaded by NHGRI called the GLEE, the Genetic Literacy Education and Engagement Initiative, that actually had a great amount of work that got put into it to think about how you educate basically at the student level, at the provider level, at the general consumer, general population level, and that didn't get the appropriate funding to move forward. I think we need to do more to basically figure out how we centralize some of these efforts, and so we're not all recreating the wheel, and really just help to figure out whether it's kind of pre-test in general population, or even when we think about physicians and providers who are consumers at heart as well, what are the point of care solutions? There's just a lot of disparate things out there, and we haven't done a good enough job, I think, coming together as a community to focus those resources.
Thank you. On that note, I'm going to turn it back to our to Greg and Kathy, but before that, let's thank the panelists and thank you to all of you for the conversation.